Good day all. This is the introduction part for image evaluation VMI 2122. I am Sachin Balakrishnan here. Okay. As you can see, these are the basic guidelines that we are using for evaluation of radiographic images. Okay, image evaluation guideline. The abbreviation is a PACEMAN. PACEMAN. Okay. What does it mean? You can see here P stands for positioning, A area or anatomy, C collimation and central ray location, E exposure, M marker placement, A alignment, and name. So when you talk about the first criteria here about the positioning part, okay, the three outcome can be observed based on each radiograph. If you're intended to do PA radiograph, it will be through PA. The positioning, we need to check the positioning of the patient in order to make sure that patient in through PA condition. Next, through AP, which is the anteroposterior, and the third one is the adequate oblique. Okay, we'll look into it. Okay, for example, let's say you are intended to do posterior-anterior. What do you mean by posterior-anterior? It's a pathway of X-ray entering the patient at the posterior aspect and exit the patient at the anterior aspect. Okay, before reaching the cassette. Okay, this will be condition of the patient standing, and we are looking at this patient from the above the head. Okay, so consider like a supero-inferior view, meaning you are looking at the patient from the top of the head. Okay, this will be the right side of the patient and this will be the left side. This is the cassette, this is X-ray tube. So the X-ray will enter the patient at the posterior aspect and exit the patient at the anterior aspect here. Okay, so this is known as posterior-anterior projection, also known as PA projection. Okay, next one is the anteroposterior projection, which is a X-ray enter the patient in the anterior aspect, exit patient at the posterior aspect before reaching the cassette. Okay, so the patient will be something like looking at the X-ray tube. This one, patient will look cassette. Okay, now another view that commonly we are doing is the PA, but it will be anterior oblique or posterior oblique. Bear in your mind that this is not known as a projection. This is what we call it as a position, because right anterior oblique only explain the patient's positioning in relation to cassette. It does not explain where the X-ray enter. So for this, if you want to write, you have to write it as a posterior-anterior right anterior oblique, meaning X-ray enter patient at the posterior aspect, exit the patient at anterior aspect. Okay, so this is a posterior-anterior. Okay, patient in currently right anterior oblique position. How we know that? Because patient right side is closer to the cassette, left side is away, so patient in oblique condition in relation to the cassette. Okay, you have experience of looking at these things all in IP1. We are refreshing currently in order to make sure that you get a good understanding before we enter the topics. Okay, so next one is a through PA, as we can see here. Okay, what we call through PA, when the distance on both sides equal to the IR cassette. There's a no rotation present, so we can classify the one through PA. This one we are looking at the anatomy from external anatomy. So in the radiograph we will look internal anatomy. We use certain guideline to identify patient in rotation or not rotation. If no rotation, through PA. Okay, for this is not called as a through PA. Why? Because patient is not having some kind of rotation here, so patient not, both shoulders not close contact with the IR here. Same goes for this third image here. Okay, not through PA also. Okay. How about for anterior projections? Okay, if we look at this, it is through AP, slight rotation, more than 45 or less than 45 or 45. Okay, if we intended to do through AP, there are certain criteria that we need to look in order to make sure that patient is not rotated like this. Okay, so not through AP. This also not through AP. Okay, whenever you look at the radiograph, you need to you need to read certain anatomy and make sure that you can imagine patient in these positions. Okay, so it will be very easy for you to identify whether patient rotated or not rotated. Okay. Okay, next one is oblique, for oblique positions. Okay, so when you do patient, for example, let's say we want to check whether patient in right anterior oblique, PA position, PA right anterior oblique. See, right side closer to the case side. Okay, right anterior oblique. So how we know patient anterior oblique is in adequate position? Okay, by looking at 45-degree. There are certain things inside the body, the anatomy that we need to refer in order to measure the patient in oblique conditions. Okay. So if this is less than 45, as you can see here, less than 45 here, so that means not adequate RAO. Okay, this one LAO, left anterior oblique. The difference between these two is which anterior side is closer to the case side. In this one, right anterior side closer to the case side. This one, left anterior side closer to the case side. Okay, and this one not adequate. But even though it is more than 45, we can look this. This one is less than 45. Okay. So these are the things that we need to check for each images. Okay, next in line for placement is a P after positioning. Then we go for A. A stand for area or anatomy. Those days the term used was anatomy. Okay, now we go for area to simplify it, because when you talk about anatomy, you need to explain all the anatomy that you can see, you should see, okay, in the certain position. For example, if chest x-ray, you're supposed to mention from airfield trachea until mediastinal structures, lungs, visibility of lungs, then visibility of costophrenic angle, hemidiaphragm on both sides. So very so many structures that you mention. So they change it to area. Area means you just need to mention that what are the structure included in upper border, what are the structure included in lower border, and what are the structure included in lateral border. As simple as that. Okay. So if you look at this radiograph here, first of all, you must know in the images, usually they will give two lines like this. Okay. Of course, we cannot give exactly like what the film is. Okay, because most of the images will be taken without borders. Okay, imagine that these are the radiograph film. The outer border here is a film border. Okay, the inner border is a collimation border. Okay, the collimation that you give. Okay, these are the borders that appear on the films. Okay, next one is the center of the anatomy. Okay. Okay. So whenever you talk about the border for area, what are the things? For example, chest X-ray here. So we need to talk about the upper border part. Upper border, it should include both apex of the lung or apical of the lung should be included. So if in this case, if you can see that the apical of lung is included, therefore you can conclude, you say, for area of this PA erect chest, the upper border include for area of PA erect chest, the upper border include both apical of the lung. And then go for the lower border. Okay, the lower border should include both costophrenic angle. Both side, both costophrenic angle must be included. Both side. So you can see both included. Then you can come to conclusion. You say for this radiograph, lower border include both costophrenic angle. Okay, now the lateral border. When you talk about lateral border, make sure you evaluate both lateral. If you see this is the left part of the patient, but we are referring to our side. The border is based on our side. Okay, the anatomy is based on patient side. Okay, the border is at our right lateral. Okay, our right. The anatomy of the patient based on patient anatomy, left side. Okay, so that's why don't get confused there. So this is the right lateral border and this is left lateral border. Okay, right lateral border include lateral aspect of the ribs. Okay, both sides it should include. So overall, how to comment on area and anatomy is very simple. You should state about the upper border. Upper border include both apical of the lung. Lower border include costophrenic, both costophrenic angle. Lateral border include lateral thoracic ribs cage. Simple as that. Now we move to the third one, which is a collimation C. Also central link placement. In this part, we will check the collimation how the collimation was given, how many site collimation was given. Based on that collimation, we can determine the placement of the CR. Okay, please put in your mind that CR that we are referring here is during the positioning part, which is IP1. When you position the patient, you are centering CR, correct? Not the cross. Okay, that cross will intersect in one anatomy. Okay, that is called central ray. By looking at the radiograph, you can identify where was the CR placement was done when the patient did the certain projections. Okay, so by using certain technique lah, okay, we will check on that. Okay, first of all, these are the collimation part. Okay, let's say this is a film border and this is a collimation, this is a marker, okay, being placed there. So you will see this one is the collimation border. You can notice that there's a 4-side collimation. 1, 2, 3, 4. 4-side collimations. This is very good. Okay, even though it's not aligned to the center of the filler, but it is having a 4-side collimation. As you all know, collimation is very important, especially to give good radiation protection to the patients. Okay, only irradiated the area that we need to irradiate and reduce the doses to the other unnecessary parts. Okay, the next one is, look at the second example here. The second example here having a 3 collimation. 1, 2, 3. Another one is missing. Okay, okay, this one still acceptable, but in terms of placement analysis, this is not good. Why? Because using these 3 side collimation, we cannot identify where was the central ray location. Okay, placement was done. Okay, this is what we call it as a collimation. Collimation must be foresight. Unless certain cases, certain position that you need to utilize the diagonal view. For example, like femur, humerus, okay, where you need to put the patient in diagonal way like this. Tendency to have only 2 side collimation is very high. Okay, that is acceptable. Okay. In order to understand about the placement of CR, you need to understand the concept first. The concept is in on the collimator here, what you can see is a field size. Okay, these are the one you use in order. The center here is the one that you are using to center the placement when you are doing IP1, which is a technique part lah. Okay, you find the center. For example, for chest X-ray, you intersect the line between the inferior angle of scapula and MSP. Okay, mid sagittal plane. So you will get a estimation place of T7 for PA erect chest. Okay, these are the one you use, but in the radiograph you need to use the X. Okay, connecting all the borders. You can see here the actual collimations, if 4-side collimation present on the cassette, so you can use that border or connect the borders, okay, using the X in order to identify that the central part. It will be similar. Make sure that it will be exactly the center, the similar part. Okay, this box here, of course, it will be magnified now because due to distance, magnification will occur. So it will look bigger here. So the center here is actually the center here. So since if you have 4-side collimation, then only you can detect the centering point using the X technique, connecting the border. Okay. Okay. Next one is a contrast. Okay, basically, if you look at the contrast, it might look like very difficult for you to understand. But if you understand the basic concept or the definition of contrast and density, it will be very easy for you to check on the radiograph. Okay, so first of all, go for the basic. What is the contrast? Contrast defined as different in density between two adjacent images. Different in density between two adjacent images. What do you mean by density? Density is amount of blackness. If you notice, inside definition of contrast, there is density. We talk about density. Okay, I repeat again. Contrast definition is different in density between two adjacent. You see density, the presence of density there. Okay. Now, what do? You bring the definition of density, replace it inside the definition of contrast. Okay, for example, like this, different in density, you replace the density there with definition of density. So definition of density will be different amount of blackness on the process image. Okay, so if you replace, what will happen? The new definition for contrast will be different in amount of blackness between process image. Okay, or different in amount of blackness between two adjacent structure on the process image. Okay, I repeat again, different in then amount of blackness, okay, between structures or between two structures on the process image. Okay, you get it? Okay, now go to this. Okay, whenever you want to check the contrast, okay, you want to check whether the exposure factor of this radiograph is good enough. Okay, you need to check contrast intensity. Remember, whenever you need to check the exposure factor of this radiograph, you need to check contrast intensity. Now, to check contrast intensity, you need to select two structures. One is thin structure, another one thick structure. Thin structure, thick structure, remember. Okay, for thin structure, look for any structure which is thinner lah in the PA chest. For this example here, we can take vascular lung marking. You know the vascular lung marking? Lung marking, the vessel which actually help us to mark the lung parts. Okay, vascular lung marking. You can see here. Okay, that's a thinner structure. You can see the thinner structure clearly. Good. Next, the thicker structure. For the thicker structure, we go for the bones especially. Okay, what you need to see is the bony cortical outline of thoracic vertebra and posterior ribs behind the ribs. Why? Because behind the heart, sorry, behind the heart. Okay. Because if you can see that one, the bony cortical outline very clearly, that show that the thin and thicker part contrast is good. What do you mean by BCO? Look at this clavicle example here. If I magnify it, it will become like this. Can you see two lines here? Two lines on the top, two lines on below here. Okay, this line, okay, that's called bony cortical outline. Every bone will have a cortical outline like this. Okay, okay, this is nature lah. Okay, it will having a cortical outline like this. If you can see that cortical outline clearly, that means the contrast part for that thicker structure is good. So the concept is, in order to measure the contrast optimum, we need to measure that thin structure can see, thick structure can see. So you can see both, contrast is good. So next one, you go for density. Okay, the density also apply the same things, where you have to check on the thin structure and also the thick structure. For the thin structure, usually we go for air-filled trachea. Okay, remember, we cannot mention as a trachea. Okay, you only can see air-filled trachea. Okay, the borders are not so clear. So if you can see the air-filled trachea, okay, remember density definition is amount of blackness. Okay, you can see, good. And for the thick structure, you should see the bony trabecular pattern or BTP of upper thoracic vertebra. If you notice, for contrast and density, usually for thick structure, we will go for bones. Okay, for thin structure, we will go for structures. Okay, like organs. Okay, so it will be differentiate like that lah. Okay, for example, for thick structure, you see bony trabecular pattern. What do you mean by bony trabecular pattern? Pattern, you can see the inner outline is the outer structure. For contrast, we look at the outline. For density, we look into the pattern inside. You can see the pattern inside of this vertebra here. Very nice, right? So clearly can see, that means it's good. For example, here you can see the pattern. You can see the pattern. So we will come to conclusion the density of thicker structure is good. So in summary, for exposure factor, to determine whether exposure factor is optimum or not, you need to check contrast and density. For contrast, you need to check thin and thicker structure. For density, you need to check thick and thin structure. For contrast, you need to check the BCO. For density, you need to check the BTP. What is BCO? The outline of the cortical bone. What is BTP? The pattern of the bony trabecula. Okay. So in simple, BTP means inside, BCO means outside. Okay. Okay. Next one. Placement of marker. M for marker. What do you mean by M? Is a marker, anatomical marker, where to place. There's a certain guideline given by the books where to put the marker. For example, if you look at this radiograph of the right hand here, PA right hand, PA right hand here, so you can see position marker in the exposure field, area within the collimated, it should be tight fill, okay, as far as away from the center as possible. You don't go too near to the center, put it at the side. Why? Because we don't want this one to intercept or obscure the region of interest, okay. But please put in mind that you don't open the collimation just to include the anatomical marker there, okay. You shouldn't do like that. Tight collimation and try to squeeze in the anatomical marker there, okay. Next one, avoid placing marker in an area that will cover up the VOI. VOI means volume of interest, or you can also call it a region of interest, or be hidden by a shield. So please be careful, don't put like this. Okay, tendency to superimpose the spine is very high here. Okay, place marker directly on the IR. Okay, IR mean cassette here, or tabletop whenever possible in a face up positions. Okay, this placement avoid marker distortion and magnification. You can see here slight distortions. Okay, distortion also can cause sometimes cut off the region of interest. Okay, it will prevent the scatter radiation from undercutting the marker and ensure that the marker will not projected off the IR. There's a tendency in that since we are putting the marker at the side, okay, away from the center. Next one is the AP and PA projection of the torso, okay, torso part, body part, vertebra, and the cranium, the skull part. Okay, for projection AP and PA of these three sections, place the right or left marker laterally on the side being marked. The patient's vertebral column is the dividing plane for the right and left side for us to easily to determine right and left lah. Okay, so if you want to see, you either want to put the right marker on the right side or you want to put left marker on the left side, acceptable. Okay. Lateral projection of the torso, vertebra, and cranium. For this three-part lateral projection, the marker indicates the side of the patient, usually positioned closer to the IR. Okay, meaning, let's say you are doing left lateral chest, you should put the marker of left, that to indicate the left side of the patient is closer to the IR. Okay, if the patient's left side is positioned closer to the IR for the lateral lumbar vertebral projection, place the marker left on the IR. For example, like this case. Okay, you see it's not superimposed. Okay. Next rule say that whether the marker is placed anteriorly or posteriorly to the lumbar vertebra does not affect the accuracy of the image marking. Although the images of markers placed posteriorly are often overexposed. Be careful not to put behind. Okay, it is better to put it at the anterior side. If you're good enough, make sure by practice you will be able to put it in nice position. Yeah? Okay. Okay, the next one is a AP and PA oblique projection of the torso, vertebra, and cranium. Okay, look at this AP and PA oblique projections. Okay, the marker identifies the side of the patient's position closer to the IR. Remember, in oblique, like we already checked the previous images of adequate. Which side is closer to the cassette? We need to label that one. If LAO means left anterior side closer to the cassette. Okay, if RAO means right anterior side closer to the cassette. In this method, we are checking that which side is closer to the cassette. We need to put that marker, okay, to indicate which side is patient rotated. Now left here indicate patient's left side is closer to the cassette. Okay. Okay. Next one, AP and PA when it called lateral decubitus projection. We already discussed during our IP1 lateral decubitus. You have to be very careful with this word because decubitus have a two different meanings. Okay, decubitus inside. Okay, the CI should be horizontal and patient should be in recumbent position. Okay, lateral decubitus projection of torso. Place the R or L marker, right or left marker, laterally on the correct side. For example, if patient lying down like this is the head of the patient and you are doing AP projection. Left side will be higher or the side up. So put the marker with the side up. For example, left side high, so you just put the left there. So this one to indicate the left side is higher and right side is down here. Okay. Okay, next one, extremities projection, mark the side of the patient being imaged. For example, if his left side is the region of interest here, okay, so make sure you mark the left. If all three examination or two examination or multiple examination only done for the same side is enough if you label with only one projection. If you want to label all three also okay, but one is more than enough. But if it is a different side being imaged in one film, it is better to place both label. Okay. Okay. For AP and AP oblique shoulders and hip projections, the marker indicate the side of the patient being imaged. This is straightforward lah. Okay. But for the cross table or lateral projection, cross table lateral projection, position the marker anteriorly to prevent it from obscuring the structure situated along the posterior edge of the eye. But to be very careful, if you place here tendency to cut off, you see the soft tissue of the patients, tendency to cut off is very high. It is better to put it in the anterior aspect lah. Okay. This indicate the right or the left side of the patient when the extremity shoulder or hip is being imaged. Its tendency to cut off here is very high. See the soft tissue? Can you see the soft tissue here? Okay. Okay. Next is about the alignment. Okay, we already covered P, A, C, E. Okay, M. Now we go for A, alignment. Okay. In the part of alignment, we need to check alignment for three things. First, alignment between the film border to the collimation border, alignment between collimation border to the anatomy border, or center of the anatomy, then center of anatomy to the film border. Okay, from there we know that whether the alignment of the image produced is there or not. What do you mean by alignment? The first one is a collimation and film. How to check? Check the collimation border here, the film border here, and collimation border. Check on both sides. If it is equal, okay. Usually we check only the lateral, the horizontal side lah. You want to check the upper and lower also can. Okay. But go for standard one. If you check here and here, make sure you check this side. Now you can see the both sides are equal. So we come to alignment between collimation films are equal. Okay, the next one, go for anatomy and collimation. You see the anatomy is this one. This is the anatomy border. Or you want to have a center also can, no problem. Center of anatomy also, no problem. Okay. And then check the distance the collimations. If equal, that means the alignment between the anatomy and collimation is equal. Then the third one, anatomy versus film. So you check the film border to the anatomy border. If it is equal, you come to conclusion alignment between anatomy and film is aligned. Why you need to check alignment? To ensure that the films taken was done at the center of the collimated area, center of the film, and apart from the artistic value, this one to prevent the cut off, mainly cut off of the anatomy. Okay, so if all these three is aligned, then only you can come to conclusion alignment is good for this film. If either one is missing or misaligned, you should say that misalignment is there. Okay. Okay, next one is the name. Name is very easy. There should be appearance of the hospital ID, patient name, and the date of examination done, plus with the radiographer's initial on the radiograph. Okay, you can either place it on the top corner of the radiograph or bottom corner of the radiograph. Depend on the body part that you are taking or image. Okay, that's all so far. So we go for summary. For positioning of the patient, we need to check whether patient through AP, PA, or adequate oblique. Okay, there are certain criteria that we need to follow. It will be better if we can understand that the criteria or memorize the criteria. So every time you look at the radiograph, you will be able to check whether the radiograph follow the criteria given. If it does not follow, then we can come to conclusion it is not following through PA, AP, or adequate oblique. The next one is the area, where we will check area, basically the anatomy that it should be included within the projections, the collimated area. If it is cut off, then we have to repeat. So usually we'll check the upper body collimation, include what structure, lateral border include what structure, and lower border include what structure. Next, collimations or CR placement lah. For the collimation, this should be 4-side collimation. Your task is just check, count how many side of collimation present. It should be 4. If it is less than 4, just state how many side of collimation you can see. 3, 2, okay. Then, if other than 4 side of collimation, we cannot use the X to detect the CR location. If you encounter any projections that having a less than 4 side collimations, okay, let's say 3, 2, 1, you just can come to conclusion CR location cannot be determined due to 2 side collimation or 3 side collimation only presence. Okay, if you can see 4 side collimation, you do the X connecting the borders, then you find the central ray placement and state where is the central ray placement being done. If it is apart from T7 also, you just state. Okay, if it is 3 side collimation, 2 side collimation, okay, you just need to mention it 2 side collimation, therefore we cannot do identify the CR locations. Okay, next is exposure. Exposure factor, you need to check two things, contrast and density. Remember, contrast for thin and thick structure, density for thin and thick structure. What you need to check for contrast, BCO. You can identify the BCO of the structures, that means the contrast is good. You can see the bony trabecular pattern, that means the density is good. What is BTP? Inner part, the pattern inside. What is outline? Is the outer part. Okay. Marker, placement and present in appropriate place. Okay, alignment between film and collimation, film and anatomy, and collimation and anatomy must be present like this. Then name, patient name, ID, radiographer's ID, and hospital should be present. Bear in mind, in image evaluations, if any one of these criteria is missing, the film should be rejected. But in reality, any of these projection criteria is not being fulfilled, usually we need to use our common sense or critical thinking in order to check whether the pathology can be seen, because you need to consider in order to repeat the radiograph, patient dose will be double. Okay, patient dose will be double. But you learn from the mistake, and the next radiograph for the different patients, next projection for the different patient, you don't do repeat the mistakes. Okay, okay, that's all. If anything, you can contact me. Best of luck.